Hi everybody, I'm Jackie, the Manager of Primary Health at the IWK, and I'm very fortunate to work with Tyro Setlong, our Diversity and Inclusion Coordinator. So we're going to tell you a bit about some of the diversity work that's happening at the IWK, try to touch on a whole bunch of things and not get into any detail on anything. So please approach us or ask us questions if you have any afterwards. So in 2009, we released our diversity and inclusion strategy, and before that time, there was a lot of work still going on around multiculturalism and diversity and lots of committees meeting. But I guess probably in 2008, there was a project team struck who decided that as part of our strategic planning at the IWK that we really needed to look at a new strategy. So the great thing about this strategy that it was informed by a lot of different people. So this strategy was actually done before I went back to the IWK, but they did meet with a lot of community partners, lots of focus groups happened, and also leadership staff gave their opinions on how they felt the cultural competency environment was. So that really helped make it a very diverse strategy. As well, there was a bunch of tools developed when we created the strategy. So the first one was a lens tool, and this lens tool is just a series of questions that it's meant to be used by staff to help them when they're developing policies and programs. And we brought some copies of the lens tool. It's actually back at our table. We also developed a position statement. So instead of having a policy on diversity, this position statement really publicly acknowledges our commitment to creating a welcoming environment. So we have copies of our position statement here today as well. We recently actually got our position statement translated to French, and we've talked about how we can actually get it translated to other languages as well. And as you'll see at the bottom of the slide there, we have had this logo since 2009, everyone, everyone, but we've now included a tagline that's both in French and English. And also we developed an audit tool, and this is the tool that was used to get feedback from staff while we developed the policy. And we've had the opportunity to redo that audit 2 more times, and it's given us an opportunity to show the progress that we've made and also the things that we need to continue working on. And I guess the most important thing that came out of the strategy development was the diversity and inclusion coordinator position. And I'll tell you a little bit about a structure, and then I'll pass it on to Tyro. So we just wanted to acknowledge, I think some of our successes are based on the structure we've put in place. So if you notice the green circles, these different initiatives have given us a lot of momentum. So Pride Health Program, which you're going to hear from Anita, it's Capital Health Program in partnership with the IWK. Also our interpretation and translation services. So we have a bilingual services coordinator who also sits within primary health portfolio. And also our spiritual health team, which also fits within the primary health portfolio. So these things all together has really helped diversity get momentum. And we have a steering committee and an advisory council that Tyro will talk about. But also wanted to mention that we have this direct link to our executive leadership team and our executive sponsor, Ann Cogden. And that's been, I think, really helped us get things going as well. So I'll pass it over to Tyro.
We thought that I could talk a little bit about my role, and that entails leading the implementation of the diversity and inclusion strategy. And as well as Jackie had mentioned, we do have the Diversity and Inclusion Steering Committee, which I do chair. And that steering committee basically as well leads the implementation of the strategy by working as champions within the healthcare center, seeing that that strategy is rolled out and everybody within the health center knows about the diversity and inclusion strategy. And our committee comprises of different health personnel within the healthcare system that is both at managerial level as well as the first line. And you also have a good partnership with Capital Health. We do have their diversity and inclusion coordinator sitting in our committee as well. And myself, I do sit in that committee as well. And as well, my role entails building relationships throughout the healthcare center programs and as well with our diverse communities. And during the development of our strategy, as Jackie had mentioned, we engaged our different communities, and they made it loud and clear that we cannot continue with the implementation of the strategy without them. Therefore, they need to be that continuous voice from the communities to help us implement our diversity and inclusion strategy. Therefore, we did form our advisory council, and that was established in May of 2011. And this advisory council comprises as well of different community organizations, and some of the members are around the table today here. It has been a very, very exciting thing to have our advisory council, because this council has so far contributed in so many ways within the work that we do at AWK. We had meetings within the African Nova Scotian communities in North Preston to kind of make conversations there and get to know what we can do better and how we can serve them better. And our advisory council were really, really helpful in that. And as well, they have contributed on our awareness event tool. I'll talk a little bit about that in the next slide. And as well, gave feedback on our IWK code of conduct. This is just a few of the things that our advisory council continues to do in part together with the IWK in implementing the strategy. As well, one of the bigger pieces that I do is coordinate cultural competency education. When we did start implementing our strategy, we collaborated with CDHA and trained facilitators, and we do have 5 trained facilitators, and these are from different departments within the IWK, and they really do a good job of providing cultural competency training within the healthcare system. One of the findings was that we need to build capacity within the staff in providing cultural competency so that we are able to work cross-cultural people, or the people that we provide services to. And as well, we do provide these trainings in different venues, that is through the new hire orientations, and as well center-wide that is open for everybody. And as well, we have team-specific sessions that are organized and tailored for our different teams, but specific to their needs. And as well, we do provide educational resources for staff to continuously increase their understanding and knowledge. And as well, one of my role entails consulting, and I do connect with different teams on different occasions to provide diversity and inclusion perspectives. Our aim is to weave in diversity and inclusion within all the programs and initiatives that we do, and my role is to sit down with them and see how we can best weave in diversity and inclusion in that. And I mentioned earlier on that our advisory council had helped us in providing feedback on our awareness event tool. And this event tool kind of promote and enhance awareness in learning of our diverse populations. It's a tool with different awareness events and days and observations that is being observed by our different community organizations. And these awareness events are reflective and consistent with our definition of diversity. And I just want to mention that when you do our awareness events, they're not only led by the Diversity and Inclusion Committee, but they are inclusive of, we do have work groups, and these work groups are inclusive of our community members, members from the Diversity and Inclusion Committee, the Advisory Council, and other people or staff within the healthcare center as well, so that everybody works together to roll out diversity and inclusion. So this is some of the pictures that of our African Heritage Month that we had a couple of weeks ago. And some of the initiatives as well that are happening around the health center include, we do have an art and signage. During the development of the strategy, our communities have clearly indicated that our signages are not welcoming. They don't reflect diverse communities that we serve. Therefore, we need inclusive images. And then we did consult or connect with our communities and had a diverse family photo shoots. If you visit our table, you see a little albums that have different pictures, and throughout our slides, we have some of those pictures that we did with our communities. And these pictures are posted around our health center to kind of reflect the diverse populations and communities and families that we service. As well as a way to increase awareness of different community organizations, we have bought Mi'kmaq children's books, and these are to enable and facilitate Mi'kmaq cultural learning. And these books have been placed in different places around the healthcare center, the resource center, our emergency services, and as well as the Ronald McDonald House or room. As well, there is work happening around the healthcare center that is that reflects diversity, and one of that includes the Read to Me bags. I do have some of the Read to Me bags, and one thing that I should mention is that the Read to Me bags are different languages. The books within are from different languages as a way to reflect that we don't only serve one language. And as well, one thing that I want to mention before I pass to Jackie is the spiritual health piece that we have included a Muslim prayer room in that spiritual piece. And as well, it used to be called the chapel, and we have adopted the name Space of Prayer and Meditation. So passing over to Jackie.
Great, thank you, Tyra. Just wanted to take an opportunity to tell you a little bit about how diversity has actually touched our work in the community. So we've been really lucky to be able to bring that lens to our community work. One example is our work with the Dartmouth Mosque. They actually approached us and wanted to get some support around parenting. And we were already running the Incredible Years parenting program in a number of communities. So we thought, well, why not pilot this specific program with the Dartmouth Mosque? So we are currently co-facilitating the program with a leader from the Dartmouth Mosque. It's going very well so far. They're probably about halfway through the 14-week series. It's interesting because there's probably about 8 mothers that have been coming, and they are from a variety of different cultures. They're from many different countries. They speak many different languages. But they're having some very good discussions, and a lot of peer support is happening. And it's a really good example of the differences between culture and religion. They all share a common religion, but there's many different cultures. So that's going very well. Here's some picture from the mosque. We also are doing an interesting project in Scotia Court. Scotia Court is a small community housing neighborhood, underserved community in Dartmouth. And the community police who worked here actually came to visit us at the IWK, and they really wanted to see what we could do to support the women in the community. We tried, we met with them, we went to some different community events, and we just weren't connecting with the women. So instead we thought, well, let's try to build some trust and relationships with this community by working with the children and youth, and it's been going very well. We've had 3 of our four-part series with the children doing a cooking class. We've hired a casual project dietitian, and she's been working. It's been going really well with the kids. And we also integrated this work with the community pastor and the community police, and also head of the Tenants Association. So the community's starting to know who we are. We hope that we're building trust, and we're hoping that we'll be able to move ahead and start working more with the women and finding out what type of support they need from us. Mental health first aid is another example of bringing our diversity work to the community. So this mental health first aid course is specific for adults who interact with youth. And we have somebody from my team, Monique Yazbak, is trained in this. And it's a program, I guess, coordinated by the Mental Health Commission of Canada, but it provides a basic understanding to people about how to help someone with a mental health problem or someone who's experiencing a mental health crisis. And we've been able to offer this in a variety of communities and have had great evaluations back. And Monique has been really excited about the conversations, and she has learned a lot about how different communities and different cultures view mental health and mental illness. And finally, I just wanted to quickly mention some of the work we're doing in North Preston, East Preston, Lake Loon, and Cherrybrook. And we're working alongside primary health care and Capital Health. But if you remember, Tyro mentioned that that's the first place that our advisory council took us to get the voice of the community. And they had great things to say about, and when I say great, I don't mean necessarily all positive, but very useful things to say, I guess, about the mental health and addiction services we were providing there, women's health, parenting supports. They had a lot of things to tell us about what we needed to do differently in order to provide appropriate service. So this has really informed the planning that we've been doing with primary health care in these communities. And right now we're starting to think about how we're going to do orientation for new Capital Health and IWK staff working there. And we know that this feedback that we've received will be very, very helpful.
And moving forward, well, we are very excited for first of the work that we are doing at IWK, but still we acknowledge that diversity and inclusion is a journey, not a destiny. So we have a long way to go. And we do realize and acknowledge the potential within the healthcare center that we need to integrate diversity and inclusion into all IWK processes, and as well establish partnership with other programs within the healthcare center. For example, we do have ethics, mental health, patient and family-centered care, women's newborn health program. We really need to work on establishing those partnerships. And as well, we are doing a little bit on employment equity, and we realize that we really need to do a good job on that. And hopefully that as time goes on, we'll be reporting of good stuff on that. And as well, we want to continue with our evaluation, both internally and within our communities, because we believe that we cannot move on with the implementation of our strategy without this feedback. So in a nutshell, that's what we are doing in the healthcare center. Thank you very much.
I'm very pleased to be here today, but I must say, while I get a chance to talk about our mental health and addiction strategy to a lot of rooms, I'm quite, it's a humbling experience, and I come here with great humility because I think this room represents the folks that we have done probably the poorest job with in terms of mental health and addictions, and it's probably the greatest amount of work that needs to be done. So I'll just say that right up front, that I'm quite aware of that. Now, Together We Can is the name of our strategy, and I left copies on all of your tables, so please feel free to take one. If you already have one, you can take it and pass it on to somebody else. We're happy to have it as circulated as broadly as possible. So just a little bit of background on how the document was created and how the strategy was created. We did have a mental health and addictions strategy advisory committee that was put in place by the Minister of Health and Wellness of the day, the Honourable Maureen MacDonald, and she had a very clear idea and vision about what she wanted for that committee, and so she selected people that you might not typically think might be selected for doing the task of identifying the needs in mental health and addictions across the province and then producing a report that was to be submitted to her. So she selected folks who had either lived experience or some expertise in mental health and addictions. And while we had someone of African Nova Scotian descent, an Acadian Nova Scotian, and a consumer and family member, they weren't meant to represent their culture specifically or their diverse community. They were really just there on their own, but it was a diverse group. And that was very important to the minister that be in place. So they did their work over about 1.5 to 2 years. There were 100 consultations and 1,200 people consulted. And the report that they submitted to the minister was called Come Together, and it was submitted about a year ago next month, so a year ago in April. And then the following month, we launched our strategy, Together We Can. And in the Come Together document, it was certainly acknowledged that there were many unmet needs of diverse groups, and so we knew that that had to be a key pillar of our strategy. So when the strategy was crafted, it was agreed that it would be a whole-of-government approach, because we also know that we need to work with all of our partners across various government departments and broadly into the community. So that was a commitment that the government made right at the beginning. And mental health and addictions issues impact all people. So I hope in this strategy that you can see yourself or someone very close to you, because it should really affect everybody. As we know, mental health at least is, 1 in 5 people will be experiencing a mental illness or mental health issue at any given time. And so if you look around this room, that's a lot of people. And then if you know it may be your friends or your colleagues or your family members or other acquaintances you have, you don't have to go very far to see someone that's been impacted by mental health or addiction. So we think that this strategy is for all Nova Scotians. We did determine 5 key priority areas, and the 3rd key priority area is Aboriginal and Diverse Communities. So that's to note that it deserved its own key priority area. It needed to be identified and named, because we could have said it applies to all of the other areas, but I think unless we name it and we have things that we are accountable for, then it won't happen. And I must say, I just joined this event at lunchtime, but hearing the spoken word presentations, it doesn't take much to realize, there's lots to do, and we have a lot more to learn. And they did a stellar job of putting some of that into a very creative language. I was going to take you on a journey through how we've done with Together We Can so far. So the good news is we have been able to implement several of the action items, and I'm very pleased and proud about that because I've had the great privilege of being able to work on implementing this strategy. But then we'll come to where does diversity fit in that, and it's not quite as rosy a story. Anyway, all 18-month-olds should receive a developmental screening. So if you think that we wanted to start early and intervene early, we wanted to make sure that all 18-month-olds were seen. So if there's a developmental issue that is identified early, you can pick up signs of autism at that age. You can pick up other concerns, and kids should be referred on. They may need to wait, and we may not have all the resources they need, but if we identify them early, they'll certainly get attention before they start school, and hopefully well before they start school. And then if your child happens to be experiencing a mild to moderate anxiety or behavioral problem, we have a telephone coaching-based program in place called Strongest Families. And that to date, with money that had already been in place and a new commitment of funding from this strategy, there are about 750 families that have benefited from that this year. And then children, your children will go to school, and so they're in the SchoolsPlus families of schools. We've placed 10.5 out of the 12.5 positions that we're hoping to hire to provide mental health services and provide a good connection to the formal system and supports within the schools in those SchoolsPlus families of schools. There will be new guidelines in schools for how to address mental health, addictions, and gambling. So some more overarching guidelines that can be in place to help children and youth develop greater resiliency and the ability to make good decisions and choices in their lives. And if a youth wants to become involved in or has his or her own questions about sexual identity, there will be more gay-straight alliances in schools. And if you go to your primary care provider, they will be learning more about how to identify and support people with mental illness. And we have heard from them that they don't always feel up to the task of doing that. And while we know that a large portion, maybe 60% of folks receive their mental health care and treatment through their family physician. So it behooves us as a formal mental health and addiction system to bring those folks up to speed so that they do feel that they are able to address the needs, which are considerable. So we're looking to find ways of training them and giving them some materials to work with so that they're able to identify more specifically what the difficulties might be, and then to be able to work with them actually in the primary care setting. So hopefully only the most serious situations need to be passed on into the formal system, and that should also hopefully free up the system so it can accommodate those referrals on a more timely basis, because we know access is a huge issue. And then if you do decide that you would like to be referred into the formal system, with our new choice and partnership approach, you should receive an appointment with the person in a timely manner, so that your first contact would be having a conversation about what's going on with you and what you would like to see different, what your struggles are, and what you would like to work on. And so that's certainly more person-focused than we have been. And we'd like to make sure that we really engage with working in a partnership with the people we're seeing, as opposed to just being the expert on one side and the patient, client, or however we refer to them, on the other side. And that's a bit of a shift in how we do our work. And so we have most of the clinics around the province developing that new model as we speak. And depending on your level of need, we're also going to be putting in a peer support network across the province, so that if you may be transitioning out of hospital, you will have additional support from a peer, and that's someone who actually has lived experience themselves. So they know what you're going through. And we know that there is great value in that. And they've been telling us this for a long time, the consumers that we've worked with, and the formal system has not always taken that very seriously. So I'm very pleased to see now that we are taking it seriously, and I think we'll be the first province in the country that will have a province-wide network. Now, not to say it's going to be huge, just so we don't raise huge expectations about it, but it is going to be a beginning, and if we can prove that it's beneficial, then hopefully it just grows from there. But we'll have folks in every district health authority, a few more in the larger areas like here in Cape Breton. And we hope to award a contract in the not too distant future, so that will get underway shortly. And then if you have an opioid addiction, we're hoping that, we're planning that there will be more opportunities for you to receive treatment and work with a team to try and address that potentially catastrophic challenge. And then if at any time the concerns that you have become fairly overwhelming, or you just feel you need to talk to someone, you may or may not be in the formal system, it doesn't matter. We have a 24/7 crisis line now available. It was just announced last week. And so you can call that at any time from anywhere in the province, and it's staffed by trained mental health professionals, and they're happy to talk to anyone, and they don't really turn anyone away. So you're not going to be told, well, I'm sorry, that's not enough of a crisis, we won't talk to you here. Anyone who calls, they'll be talking to you, and they can arrange for people to be referred into an emergency department if need be, and taken to an emergency department, and that now happens all across the province. It was originally happening here in the Capital District, but we're happy to say that it will happen anywhere. And we have 6 communities in the, or 6 municipalities in the province that are looking at the harms related to alcohol, and they're trying to figure out ways that they may address those in their communities. And we will have organizations all over the province who will be providing services and supports to make life better for those living with mental illness and addictions issues. And those grants should be announced any time now. We'll also be working with employers to help them learn how to recognize and support people that may be struggling with mental health issues. And also trying to create psychologically safe and healthy workplaces, because we know many adults spend a good chunk of their time at work, and if that's not a good experience, then that's not very helpful in any part of your life. So we need to make sure that places are safe and psychologically healthy. And those are just the first year activities in Together We Can. So we think we're doing not too badly. I'll just draw your attention to the back. This is kind of my work plan. It is a 5-year strategy, but we're doing it where we've identified 3 years on the back of the document to say that we will be initiating all of our 33 action items within the first 3 years. So we've initiated all of the first-year action items, and we've actually gotten started on a couple of the second-year ones. So we think we have that well in hand. So where does diversity fit in all of that? Well, I'd say historically we've not done a great job in identifying and addressing a diversity in the formal system. And so we've learned that we actually need to talk to people of diverse communities to figure out what they need and how we may best meet those needs. I'm encouraged to hear from the IWK, and I knew that they were doing some very excellent work in that area. And so there is good work going on out there, and we need to tap into that, and we need to initiate more within our system because we have a lot of talking to do to figure this out. And it isn't going to be sort of a one-size-fits-all, and we can't just pay lip service to it. We actually have to have the discussions. We have to hear some probably fairly difficult comments and feedback, and then we have to get down to making things different and better. So we're learning that cultural safety for First Nations citizens is really critical. and that any work we do needs to be focused on that. And so for the clinicians that are doing work with First Nations citizens, we need to provide them with that. And we will develop a cultural safety training package and offer it to our programs, but we're hoping that it'll also move more broadly, because that applies to anyone in the healthcare system working with First Nations. And then the importance of language. First Nations, Acadian, Nova Scotians, very important. And we've not really taken that as seriously. I think that we've made every attempt to certainly find French-speaking clinicians, but it's really difficult. So the other thing we need to do is encourage folks to take this on as a profession. There's very interesting work to be done, and we need our workforce to be more culturally diverse in order to meet the needs more effectively. However, I know that I made one, it's not a mistake, but it's just pointed out to me that, of course, I have this document available in English, and we did print some in French, but we don't have a large number of them printed in French. So now I have to go back and make sure that we have some printed in French. That's not a hard thing, but it's just one of the many things that we just have to keep greater track of and make sure that we actually do. And we can't just say, yes, that's very important. We have to actually do it. And so that's our task. We will be coming out with an update in May, and we need to make sure that that's circulated broadly in both languages. And I did learn in a recent event that I was at that a gentleman who spoke French but was quite bilingual and spoke both languages well became very ill, and he got to the point where he was only able to understand French, and people were speaking to him in English, and so things were lost, information was lost, and they didn't quite understand what was going on with him. And that's quite a reality. So I think in the mental health world, people get quite ill, and if they revert to their native language, such as French, and they're with people that don't speak that language, then some very important key information is lost. So we just have to find ways that those kinds of situations are prevented. So one of our guiding principles in the strategy was nothing for you without you, and we're borrowing shamelessly from the UN Convention on the Rights of Persons with Disabilities, and we want to make sure that we're held accountable to that, so that if we're doing work in different cultural communities, that we involve people from those communities. Obviously, it's a partnership that we have to establish. And we have started those conversations, and so I'm very pleased about that. But what it does remind me of, or make me more aware of, is that there's a lot of work to do, and it makes all of us aware of that there's lots to do. Now, what we've been really pleased about is that people have been more than willing, quite forgiving, and more than willing to work on this. So I think there's lots of opportunities. I think that this is a good time to be approaching all of this work, but there is a lot ahead of us. And eventually, when we figure out some of these things, we need to make sure that the system has the capacity to provide services in a more appropriate, culturally safe, culturally competent way. And that's the whole outcome that we're looking for. And then it gets even more complex, because there's intersectionality. So we look at poverty, disability, gender, sexual identity, history of abuse, all of those things. If you layer that on top of culture, and you layer on top of that a mental illness or an addictions, it's a very complex situation. And you can only imagine living with all of that, or any parts of that. So we need to understand all of the components that go into why somebody may be seeking assistance in the formal system, or what our primary care providers are seeing in primary care practices. So just in wrapping up, I would say that those of us in the majority community, that would certainly be me, have lots to learn from you in the various cultural and diverse communities. I'm pleased that government has made it a priority, and that it's a priority in our strategy. Nova Scotians not in the majority community deserve better from us, and that is our task that is laid ahead of us. And I know that it's one of the goals of Together We Can. It may take the 5 years of the strategy to achieve it, but we are well on the way, and we will continue to strive to get that done. So thank you very much.
Good afternoon, everybody. As Chair mentioned, my name is Anita Keeping, and I'm the Clinical Nurse Specialist with Pride Health, and we are a program of Capital Health in partnership with the IWK, as Jackie had mentioned, so everything seems to be all connected. So I just want to talk a little bit about our program and our theme for the year, which was Raising the Flag. It was a big project that we had last Pride Week in making sure that as many of the facilities at Capital Health raised the Pride flag during Pride Week, so we hung on to that for the year. So what is Pride Health? Pride Health program provides safe and accessible primary health care services for people who are gay, lesbian, bisexual, transgender, intersex, or queer. So you'll see GLBTIQ. And as it may have been discussed in other presentations, I'm sure, this is just one collection of those letters, the ones that we just happen to choose for our programs. By meeting people in the community, in community locations and places that are safe, we hope to establish relationships and build trust as a means to improve the health of the Rainbow community. So that's a lot of what I do, is going out in the community. I go to the Youth Project, I go to the AIDS Coalition, I go to Stepping Stone, or any other place where the clientele might determine safe for them. I've gone to some of our community mental health locations at times. And when I'm there, I can meet one-on-one with people and provide services such as anonymous HIV testing, hepatitis vaccinations, referral to mental health and other services. Lots of services for helping transgender people access services as well. And currently, we're the only health authority that has this program. There's nothing like this in any of the other health authorities across the province. Now, that's not to say I don't get phone calls from people across the province. I do, and largely because we are it. So people in this small province hear about our services and they call to find out, well, what's for me in the Valley, what's for me in Cape Breton. I also even get calls from PEI, New Brunswick at times. So word gets around. And that can be a bit of a struggle because you see in the last line here, Pride Health consists of me, and I'm half-time, and our coordinator, which is a 0.6 position. So we're it. So it's fun, but it's challenging to be able to provide all the services to all the people who really do need them. So what we found is in Nova Scotia, the GLBTIQ population is the largest invisible minority in the province. So in other words, you can't tell by looking that they are one of our minority and diverse populations, but it is large. And depending what statistics you use, a lot of people typically use the Kinsey approximation, which is about 10% of the population. So if you're looking at 10%, that's about 100,000 people or so in the province, which is large. And of course, it is spread across the province. We suspect that there certainly is a larger proportion here in the HRM because quite often members of the community tend to migrate towards the cities where there's more services. But there certainly are populations in the rural areas as well. So why did we even decide that this was a program that was needed? Well, we know that nationally in this population, life expectancy is lower overall. We have seen higher rates of substance use, we've seen higher rates of obesity, we've seen higher rates of suicide, suicide attempts, and death from suicide as well. That's been documented. And across the lifespan as well, there seems to be substandard access to health care. And part of that sometimes is, well, it often stems from people who have a bad experience in the healthcare system. They've had an encounter with a homophobic or transphobic healthcare provider. And all you need is to go through that a couple of times before you start thinking, I'm not so sure I want to access healthcare unless I really need to. One thing we had found years ago when there was some focus groups done here in HRM was that a lot of GLBTIQ populations, quite often their point of access to care was the emergency department because they waited until things were just so bad that they had to do something and they didn't have much of a choice, so they went to the emergency department. And that's not acceptable for me. I want to make sure that people can have access to services that are very welcoming to people of all backgrounds, including our GLBTIQ population. Because I have heard certainly stories about people going into their doctor's offices and trans people, for example, transgender people being told, oh, no, I don't look after people like you. You'll have to go find somebody else to look after you. And these are bits of feedback that I'm hearing from people. So that's actually one of my bigger challenges too, is actually finding family doctors for people for this population. That's one of the larger phone calls that I do get actually, and that can be a very challenging one. So ultimately, yes, so we have found there's been systemic and individual discrimination in the healthcare system, and also too, just a general lack of knowledge and cultural appropriateness. Things like gay men going into their doctor's office and telling me that every time they go to see their doctor, he insists that they get an HIV test, even though they might be in a safer relationship and practicing safer sex than maybe the next straight person that comes into their office. But there's that assumption that if you're a gay man, you need an HIV test every time I see you. Transgender people as well have complained about often being used as what they call guinea pigs, and doctors bringing in their staff members and saying, oh, you have to have a look at this person. And they're not just there for the teaching purposes of everybody else. So Pride Health is regularly contacted by people from across the province looking for healthcare assistance and looking for practitioners in their area who are known to be culturally appropriate and knowledgeable. But again, the fact is, quite often, I don't have a lot of answers for them, and especially in the more outlying areas. So I always am very excited when I find out about people who are from outside HRM who have an interest in this field. So if you want to come and talk to me, I'm always happy to meet you. One of the things that we're trying to do, and this is one of our goals for this year, is to create a safe practitioners database. So we're working on this province-wide database of self-identified healthcare practitioners who are culturally appropriate and knowledgeable or specialize in working with this population. It's something that's been talked about for some time, so we figured now's the time to finally try to put this together. What we've decided was it's going to be something almost along the line of the Ally program, in a sense, that the Youth Project is doing. It's going to be people who are, as you said, self-identified. So we will have a series of questions that we will ask people before they're put on the list. And then hopefully that'll be a resource that can be used for people across the province to see, well, who are the doctors, the nurses, the physios, the massage therapists, the speech therapists, whoever it might be, that are actually knowledgeable in this field. So one of the biggest issues that I found is needing to increase access for health care for transgender people in particular. So right now in Nova Scotia, anybody who has issues with, who might have gender dysphoria, who wants to look at exploring gender issues, might be looking to transition, really mostly they have to travel to Halifax in order to be able to do this, which can be stressful in many ways, both from a travel point of view, taking time off work, taking time from family, and then the money that costs. So the few people that do work in other parts of the province who provide this care, often they feel like they're working in isolation. There might be, one person working in the valley that I know of, one person working up in the Amherst area. So something else that we're trying to do is also form a network of people who are interested in transgender services as well, so that they have people they can bounce ideas off of and discuss cases and get help as well. And right now, the maritime regions, so Nova Scotia, New Brunswick, PEI, we're the only region in Canada that doesn't cover any form at all of sexual reassignment surgery. And this is actually something else that Pride Health has been looking at over the last year or so, because there's been such a need, so many calls to me looking for people wondering, what do I do? Where can I go? How do I get surgery? And right now, they have to pay out of pocket, which can be anywhere, depending on the surgery, $10,000 to $20,000 per surgery, sometimes more. But right now, no, Nova Scotia doesn't cover anything of that sort. So along the lines of transgender health care, what we're doing now, so actually yesterday and today, so I'm kind of taking a little in between from this workshop that's going on, because yesterday and today, Pride Health is hosting this CME certified training to increase the capacity of healthcare workers across the province to provide care to trans people. Specifically, hormone assessment right now is what we're looking at, because right now in the DSM, the way it works, there does have to be a certain degree. It's more limited in the DSM-5. They'll be coming out in May. But there still has to be some connection with a therapist or a doctor of some sort before they can be referred to an endocrinologist for hormone treatment. So, and within that, as I said, we're working on that province-wide network of healthcare practitioners who will work with trans people on a primary or specialty care level. So what can be done provincially? So I'm hoping that people will seek out and become familiar with their healthcare providers in their area who are providing care to this population. And again, if you know of any, please let me know, or if you're one yourself, please speak to me. And also to talk to people in your district about GLBTIQ care, having that dialogue, and actively promoting and supporting healthcare professionals from your districts to attend training, like our CME training, when we offer them. And I guess questions will be for later. Thank you.
Good afternoon. My name is Bruce English. I'm Director of People Services at Capital Health. I'd like to talk to you today about employee equity and things we're actually doing at Capital Health. And maybe just give you a little bit of history and context of who we are. I mean, I expect you all folks do know that we sort of look after, in terms of for healthcare, for about 400,000 people here in the HR region. And we're the tertiary center for all of Nova Scotia. We cover about 1 million people. We have 9 hospitals. We have 34 sites. On a given day, we have about 11,000 staff, between 10 and 11,000 staff. Somewhere in the vicinity of about 1,100 physician or medical practitioners, 2,000 volunteers work with us every year, and about 3,000 learners come through our doors. It's a big place. And in terms of it is, in terms of the organization, we're actually an organization that's been amalgamated over the last 15 years. We probably, in terms of organizations that came together in Metro, with the VMB, the infirmary, the Dartmouth Health, Dartmouth General, in terms of stuff, in terms of some of the other regions. So probably up until a little while ago, we probably had about 7 or 8 separate cultures in this organization. And part of us is that we say we sort of refer to ourselves as a work in progress. One of the things in terms of really work in progress that we're really working here with is in terms of what whole things we're doing with diversity, social inclusion, cultural competency, and employee equity. We've had a very active group of people working in terms of these areas probably since the early 2000s. This group came together in 2003 in terms of activists in the group. We've updated in terms of in terms of our infrastructure or formal infrastructure. We have 2 diversity and inclusion coordinators. We have an interpreter coordinator. We also have in terms of official languages. We've had it for our process in terms of us working on a lot of the initiatives that people talked about here today. Jackie talked, the folks from CDHA talked about. We have all that kind of stuff. Just in terms of, and I say that because I really want to concentrate a little bit in terms of just the employee equity. So one of the things part of with all other work, we have a very active group in terms of the diversity and social inclusion group. Again, composed of people that are paid to do this and people in terms of our activists. I always say the activists in this area are really your unsung heroes. They're the people that actually hold a mirror up to you, what you're doing, in terms of a mirror up to what you can do better. So it became apparent to us, I think some time ago, that there's a patient at the end of this, somewhere along the line, in terms of for us. And what we sort of came to the conclusion was that the patient is going to come to us. They come as a whole person. People talked about that early today. And they actually want to see someone like themselves. They want to be serviced like somebody themselves, somebody who knows who they are as a whole person. We're obviously working with people in terms of across the whole spectrum on cultural competency, but it's important that we actually reflect the community in our organization. So to that effect, back around late part of 2011, we did a diversity survey. I heard people talk this morning about how would you put one together. Well, we put together a pretty elaborate survey. We surveyed about 11,000 people. We looked at, and we took our data, we compared it against census data. We didn't look at just in terms in particular couple of ethnic groups or in terms of, we really looked at the whole gamut in terms of people, where they came from, in terms of who they came as a whole person. So we looked at those kind of stuff, and then we sort of compared where we are with the census data. Now, we got back around 2,800 responses, which is really about a quarter of the population was surveyed. Fairly large statistical sample, and what it really frankly said to us, as an organization, we actually mirrored pretty good HRM. However, when you looked at specific parts of the organization, we may have measured up or maybe a little bit more, but there was whole parts of the stuff, but we just didn't have enough people in terms of representation. And particularly in places like our acute care. Sometimes that's part of it's historical. It's basically in terms of who got into the education system and who progressed through it and how people were attracted into positions. So what we found ourselves are in a lot of that particular area in our acute care. We find it in our doctors or physicians, we're in pretty good shape. But if we look at it in terms of bedside care, we look in terms of the people that are doing our testing, our people in terms of radiotherapy, along those lines, it's not where it should be. Now, some of that stuff is also comes to fact is that we're not training as many of these people today as we used to. So we did our survey, and then that generated the next part. What do you do with this? So what we took at that point in time was two things. One is we made up a decision that we really want to reflect the community. So there's two, if you really want to drive change in an organization, it's good to have initiatives. But frankly, at a certain point in time, you really have to try and institutionalize it somewhere along the line of basically going formally out and saying, here's what you're doing, and then you put resources and plans around it. So the two sort of plans that sort of came out of it, that sort of driving where we really are in terms of employment equity. First is our corporate strategic plan. And we've been running corporate strategic plan in some form probably for the last 5 or 6 years. Each round we get a little bit more sophisticated about it in terms of what we do. And we drive our budget around it in terms of in strategic themes. So one of the strategic themes we have actually is patient-centered care. And part of that theme, what we have in there is having a workforce that is culturally competent and diverse. That's a piece of it. So that's actually part of our corporate goals. And it's also in terms of really, there's measurements that go with it. And for us to, we'll do another survey to see once we've bench lined and as we start to do activities, here's where we'll go with the next round of it and see how we're done for our monitoring and for evaluation. It also helps to drive our budget in terms of us to be able to put money into these resources rather than sort of relying necessarily on volunteer work. The other piece on this that comes from it is we do have a strategic plan that was developed by a lot of stakeholder input, both inside and outside the organization. And the stakeholder input really had a couple of major themes that came out of it, but one of those major themes that came out of this strategic, and specific this, it's a 4-year plan, was employment equity. So then that generated, in terms of, again, another piece of it, where we're really about what do you do to make changes in your employment equity. So we know that we are actually deficient in some areas. So there's a short-term process and a long-term process. So in terms of a short-term process, we recognized is we had to actually have a distinct policy. So there is a distinct policy. It's formally, it'll be sort of announced and out by the organizations in early April. And we've shopped it around to a lot of people. And I say that in a sense because it really was important that you had a good opportunity to hear people what they liked about it, what they didn't like about it, went back and changed it. And that sort of a couple things what it does, it commits us as an organization to have a diverse workforce that represents our community or reflects what's in our community. And it also sets out very clearly what the accountabilities are for various people in the organization. Vice president people, what the HR function has, what the function of individual managers have to do, what employees have to do to make it a welcoming opportunity. And that's a little bit in terms of some of the stuff. Some of the stuff is going to be, when we drive it down, we're asking people to behave differently. So what we end up doing is that issues the policy. Policy by itself, without an implementation plan or an education plan, doesn't go so well. So what we've also devised is we've run out an education function, with our education facilitators, we've developed a training plan for managers, which then they can take in terms of to their employees. We've run about 4 pilots of this. We've sort of worked it over now. And now the plan is starting in early this fiscal year, coming fiscal year, is to start to roll it out. there's about 200 people who actually hire people at Capital Health. That's really when you sort of look at it. Those are people who run from supervisors straight up to terms of vice presidents. And so our role is to actually make sure that they get the education to know what their accountabilities are and what they can do. So that's the next piece of that. And then we start to monitor. Also, HR is going to change some of the process. A couple of things we've done, and just so people understand, is 60% of the hiring that we do is actually inside. People come in through casual employment. We actually structure that probably in the last year to try and include more diversity candidates in that, and we're actually starting to see that. So the diversity candidates are coming through casual, they come in, they get an opportunity to look at for permanent employment. We turn over a lot in terms of people's positions and moving, so we know that in fact we're actually starting to see some changes. We'll start to monitor that and measure that when we do our survey. Other piece that we have, we're working with our external partners to look at, and in terms of the education, to look at particular ways for us to target particular groups. We're actually right now, for example, with the Department of Health, we bring in co-op students. Co-op students come in, there's about 196 of them this year that will come right across the whole systems. Before, it was a lottery system. What we've done over last year and this year with our partners in DHW and the other DHAs, we've made a concept to allocate a number of positions for those candidates. People coming at the end of the third year co-op, do well, will get an opportunity for a full-time job in their graduating year. That's how we start to introduce people. We also work in terms of volunteers. We have, at any given year, over 2,000 volunteers. It'll be about 600 to 700 coming in. So who those will be of actually learners. A lot of those people we're trying to actually attract with diversity candidates into our functions. I guess finally, the last thing I would say, just sort of in terms of summing up, is we're, again, a work in progress. These are sort of concrete steps that we're taking, and in terms of it's been able to sort of action to a change management methodology to get it done. Thanks very much.
Thank you guys for sharing your best or your promising practices. Now we have time for a few questions.
When people are gaining employment there, is there some way to self-identify?
When we did the original survey, we spent a lot of time with a lot of communications that went out at a time. Because there had been a couple of, I think, some instance of other people surveying, both in HRM and the province. There was some pushback at a certain point in time. We made it very clear to people, we gave it voluntary, but we did put a push on, and I think that's part of why we got about a 25% rate. In terms of, we do an orientation. We give people the opportunity to self-identify if they want. Again, it's not a mandatory thing. But what we'll get in terms of it, really in the end of it, because people move around, and people stay with us, people come for permanent times. I think what will be for us is as we make changes and stuff in terms of whatever, we'll look for the biannual survey to be, frankly, probably our touchstone to look for.
Thank you very much, guys. It was really informative.